I'm Bryn Austin. I'm faculty at the Harvard Chan School of Public Health in the Department of Social and Behavioral Sciences and at Boston Children's Hospital in the Division of Adolescent and Young Adult Medicine. And I'm the director of STRIPE, the Strategic Training Initiative for the Prevention of Eating Disorders, a public health incubator. And we are delighted today to be co-sponsoring this talk with the Interdisciplinary Program in Population Mental Health at the Harvard Chan School of Public Health, headed up by my colleague, Dr. Karsten Konen. And together, we're sponsoring this talk with a colleague of ours, Dr. Sukning Chua, and we're delighted to have her with us from Singapore. So she's very graciously stayed up late in the evening to present to us here in the morning for this call. I should correct that, actually, here in the morning in Boston, but actually all hours for our audience, which is actually logging in from around the world. So we appreciate her doing that. Striped, I'll say a word about that, is a research and training program for students, junior faculty, and faculty of all ranks, and researchers out in the field. We have a special emphasis on policy translation and have a wide variety of projects for our research and training, all around addressing environmental factors that affect body image, and with the goal of making the world a better place to help young people grow up at home in their own bodies and within a sense of well-being to be able to engage with society and to make change going forward. What I'd like to do now is introduce Dr. Chua, and then I will turn it over to her to begin her talk. She's the founder of Relate Malaysia, a not-for-profit organization dedicated to the provision of mental health services, education, training, and advocacy since 2015. She's a clinical psychologist, international researcher, and educator, and her interests include motivation, self-regulation, mental health interventions, and a variety of other topics. We're delighted to have Dr. Chua join us this year as a virtual visiting scholar with Striped. And we are collaborating on a number of research projects, including estimating the prevalence of eating disorders in Singapore and Malaysia, and examining disordered weight control behaviors, cosmetic surgery, and the use of skin lightening products in Asia. As an eating disorder specialist and renowned mental health advocate, Dr. Chua has been a sought-after speaker over the past decade, appearing on radio and print media, as well as delivering 3 TEDx talks in recent years. A clinician who practices in Singapore and Malaysia, Dr. Chua is recognized as a driven and determined thought leader in psychology throughout Southeast Asia, motivated by a desire to raise the standard of mental health on an individual, organizational, and societal level. With that, please join me in welcoming Dr. Chua and her presentation today for us.
Thanks, Bryn, and thank you all for joining us, I think, quite early. I'll do my, I think what's a mandatory Asian thing and say that's way too much praise for me at this point in time. But I'm really grateful that this opportunity to share about our work in Malaysia and some of the research we're doing. So I'll start with talking about Relate Malaysia. We'll talk about some research findings, and then some a hypothesis about what might be contributing to what we observe in Malaysia. I'm going to assume that many of you are not familiar with Malaysia, so bear with me on a very brief history. Malaysia is quite a small Southeast Asia country. We have 33 million people. It's an upper middle income economy, and it's known for its multicultural society. We have 3 main ethnic groups: Malays, Chinese, and Indians. It's actually a little bit like the U.S. It's a combination of states. So we've got 12 states and 3 federal territories. That's not really important to today's talk. But what might be more important is that we have a history of being colonized by Portugal first, and then Holland, and then the British. And some of you are familiar with the way I guess the British Empire handled their colonies. They engage in a divide and rule policy. So when Malaysia was developing as a nation, what was important to the economy was rubber tree estate. And so a lot of migrants from India were brought over, and tin mining, and a lot of migrants from China was brought over. So that's where the sizable population of Chinese and Indians came from. So the British divide and rule meant that they kept these ethnic groups quite separated, you know, in terms of career, even place to stay, geographical location. And the Chinese were very involved with trade and businesses. And so we did see an economic gap grow, where the Malays, the majority group, was overall, I guess, not as economically well off as the Chinese. In the 1957, we have independence from the British rule. But, you know, as I think what we see worldwide is that when you have one economically well-off minority group and a less economically well-off majority group, they're bound to clash. So in 1969, we see some racial riots, and that led to affirmative action policies. So actually meant to help the majority group of Malays benefit. Now, over this about 50 years, that has been, it started with good intentions, like I think a lot of these policies do, but it has been used to, I think, further divide the society by race and religion. So by constitution, Malays are Muslims. And that piece, I'll throw that out there because that's actually an important piece of information when we look at disordered eating behaviors, you know, what might be contributing to the prevalence among Malays. So here we are actually on the ground. I think we get along really well. You know, I really love my country for that reason. But officially, we don't get along as well. And I think what we see in the States, it's not unique to the States, where there's more segregation and I think more extreme views. We also see that with Malaysia, you know, rise in fundamentalism and racial divide. And I think that's really unfortunate and quite sad. But that's where we are right now. I think one thing that hopefully unites us is mental health, you know, because mental health would be something that I think all ethnic groups can get on board on and come together and work together. So that's my hope anyway. And I think so far we have seen a lot of collaboration across ethnic groups. So mental health systems in Malaysia is quite new. Graduates of psychiatry, local graduates, was actually in the 70s. So right now we have like one psychiatrist and one clinical psychologist per 100,000, which means, you know, about like 300 psychiatrists and with 300 clinical psychologists in total. And a lot of it is, a lot of them work in urban areas. And so the more rural areas or in certain states where they're not, you know, I think economically well off, you don't actually get a lot of mental health care available. We don't have a lot of money for developing resources and treatments. The national mental health budget is actually less than 1% of the total national health budget. And we don't have a lot of data. So there's no national epidemiology study in Malaysia. So Relate Malaysia came about in 2015, and it really started, it grew very organically. It started with me recovering from actually depression and looking around and noticing that, you know, that the personal stigma for me was really something to fight against. And realizing that if I have all this wealth of education and all the knowledge, but yet it was difficult for me to even seek help, I felt that, you know, what more for people who don't have high mental health literacy and don't have access. So it kind of grew from there when I was like, you know, how do we educate people? How do we tell people about mental health? And then the next step was then people saying, okay, you convinced us, then where do we get help from? And it's like, good question, you know, like where do we get help from? And one thing that I really wanted to bring over, as I was trained in Canada, I really wanted to bring over what I learned in Canada in terms of the professional standards and quality of care. So we provide accessible services, and we do it all online. And there are several practical reasons for that. One is to keep our overheads low because we're not funded. And two is to reach more remote areas that don't have any access to mental health care. So if we started a physical location, I think that would perpetuate the problem that all these services are centralized in urban areas. And the third is research. So I'm a clinical psychologist, and in grad school they didn't teach us that policymakers don't read journal articles. It might seem like common sense now, but it was really a surprise to me that I was like, what? Like journal articles isn't going to drive change in society. I mean, it forms the basis, I think, of what we do, but we really need to translate the findings in ways that can be applied by policymakers in ways that make sense to them. So I've sort of changed, expanded, I think, my research interest to how we actually going to change the system, because everything we do is still quite, it's like a miniature version of a mental health system, just to show like this is possible to have affordable mental health care, is possible to increase mental health literacy, but it's beyond our scope to roll it out to the whole nation. So how do we get people on board? So just a couple of slides on what we do. We have monthly Facebook Live talks for free. If anyone listening in would like to be a speaker, please let me know. We do podcasts as well, and we collaborate with local government to develop and access mental health literacy workshops. Now, and this kind of speaks to cost, which will be sort of a running theme in my talk, that there are really good mental health literacy workshops developed in Australia, is implemented worldwide, but it's expensive to run. And the conversion rates really don't benefit us at all. So we need to, in order for us to do anything, we a lot of times we end up needing to develop our own resources. And now I'm trying to look at how can we test it out to make sure at least effective. And so it's good that it's localized, but at the same time, it's partly out of necessity that we're doing this as well. We do professional training. Practicing as a clinical psychologist in Malaysia, we're not a regulated profession, so anyone can practice, actually. Anyone can call themselves a psychologist. Theoretically, we have a law, the Allied Health Professionals, but it hasn't really been implemented. So professional standards are lacking. And what I wanted to do was bring over, sort of recognize mental health professionals. And COVID-19 has been difficult for everyone, but in many ways it's been a blessing for us, because then everyone moved online, and then I could invite these speakers for a much lower cost, because I didn't have to pay for their airfare, I didn't have to pay for the hotel bills, so I just needed to pay for their speaking fees. And we do that because if, again, with cost, Malaysians can't afford training abroad. So at least we bring them over, we charge really at cost just to cover the speaker's fees. We do mental health screenings, and this is part of our service to them. And in 2020, we really see an increase of people wondering whether they're depressed or anxious. It's been a difficult time for all. And so here's our psychological services, our online platform. And at any one point in time, we have about 80 active clients. With COVID-19. It's gone from one sign up a day to sometimes 5 signups a day, but we've been actually unable to cope with the demand for services. And I'm needing to balance between making sure my team has enough breathing space, but then as well as, the demand from the community is growing. And it's, I think there's sometimes not recognized, that even with the vaccination, people's need for mental health care has increased and won't decrease for, I think, the foreseeable future. On average, each client attends about 12 psychotherapy sessions. We don't limit it, although, because of demand, we might have to cap it. The highest so far we've had is about, I think, 60 sessions. As I do the training of our therapists, which our team of 10, which is a combination of grad students and volunteer professionals and some part-time professionals. So this is our stats. We use the OQ45.2 TA, if any of you are familiar with it. It just tracks outcome session by session. And we see, I think we have pretty good rates. Community rates, Hansen et al. 2002 did demand analysis and looked at like the recovery rates usually about 14%. And we have 29%, we have 23% who improve, 43% who no change, and some people do deteriorate. And on average, we drop about 20 points. And this is, again, is online. So I think this attests to the, that online therapy can be effective. And I think it's a feasible low-cost solution to ensuring that people in remote locations access help. And then our research, which is going to lead nicely into what we're going to talk about today. I've had to start, I'm not an economist, but I had to start with looking at health economics to present the case to policymakers and corporations about why they should care about mental health. This was somewhat difficult, so I did get a lot of help from overseas collaborators to try to calculate the economic cost. And so we started with the business cost, mental health at the workplace, and this year we put out something on youth suicide, the economic cost of youth suicide. We also launched a brief reports publication online only because that's something that's lacking actually in Southeast Asia and probably more broadly Asia, that there are no think tanks that focus on mental health exclusively. So we wanted to give a platform for that. So how do we decide what research to do? Well, we go, what are the gaps? And the gaps are everything. What's necessary for system change? And that's where we went with, okay, trying to get people to pay attention, which is the economic piece. And then because actually I'm the only researcher on the team and it was the most affordable, missing piece with the highest impact. And that depends on our funding. I have another full-time job to support myself, and time and expertise in collaborators, because my research is actually in a lot of it is in social psychology. So I've had to learn a lot of things on public health and how to expand from that, and as well as society's readiness for change. And that will, I'll lead to that. Where society is right now is that people are focusing on decriminalization of suicide. So suicide is suicide attempts is a criminal act in Malaysia still. It's actually a law that we inherited from the British, but we never got rid of. And so that's what society is paying attention to. That society is not yet paying attention to, disordered eating and the cost of that. So I try to be more strategic with it if it's going to have high impact, that's going to actually help the conversation move forward. So from economics, right now, where I wanted to go was epidemiology, because we need to understand the scope of the problem. And so I'm collaborating with the WHO World Mental Health International College Student Initiative. And the main reason for that is because the World Mental Health Survey is too resource heavy for me. This is online and something that we can more easily roll out, at least to get the ball rolling, and at least to get Malaysian public policy professionals, policymakers, community leaders noticing that, paying attention to, this is something that we actually need to understand and quantify. I also look at the disordered eating, and it's been mentioned, we look at the prevalence of eating disorders in Malaysia and Singapore. And I've got collaborators looking at more broad body image issues. And I think some of my collaborators are here, so I'll shout out now to Nadia, Flora, and Wipada, who's been really great people to work with. So naming the problem, and another one that, as I mentioned, suicide attempts is a criminal act. And there's been a lot of talk about it. It's obviously something that the media loves to cover, and policymakers are willing to talk about it now. And so there's actually, I think, a lot of will to decriminalize it. But unfortunately, the dialogue is, like many other mental health issues, is dominated by policymakers and mental health care professionals. So one thing that I want to make sure is that we don't neglect people with lived experiences, that we not just take into account their view, but make them, give them a seat at the table for policy making. That what they have to say is valued and seen as equally important as what healthcare professionals have to say. So I've teamed up with my collaborators, Pat Corrigan and Lindsay Sheehan at Illinois, using community-based participatory research to tackle. And our first step is to look at the stigma of suicide. And with all the interventions, people always ask, and then what do we do about it? So we are looking at interventions, and primarily digital interventions, in line with my trying to be as low cost and resource light as possible, and to reach as many people as possible. All right. What are the barriers? Everything. We have funding is low, lack of trained professionals, stakeholder buy-in. Mental health is still seen as maybe a some people thing. Some people should care about it, but not really everyone. Mental health literacy is quite low. Community support, not really there. And stigma, it's we talk a lot about it, but we don't have any public health campaigns to address mental health stigma, or even for help seeking. There are some, but they not, I think, haven't been shown to be effective, at least. All right. So from that, let's move on to our research. And these are my collaborators, Nadia, Flora, Wipada, and Bryn. And we looked at body image. And so body image is how you see yourself when you look in the mirror, or when you picture yourself in your mind. And this is taken from NEDA, the National Eating Disorders Organization. And so it covers actually, your beliefs, your emotions, and your behavior. And a lot of times we think about body image, usually in terms of weight and shape concerns. And so this is a tripartite influence model of body image, which talks about how social cultural influences, primarily family, peers, and media, can influence how people feel about their own bodies, and then lead to disordered weight control behaviors or disordered eating, and affect their psychological functioning. So this model has actually been tested in Malaysia, and yeah, there's pretty good evidence that it's a valid model. The thin ideal is quite prevalent in Malaysia, much like the US. We are influenced, and I wouldn't say it's just influenced by Western media. Our local media and media from neighboring Asian countries also emphasize a certain shape, which is usually on the thinner side as well. So, it's perpetuated by I think Asian media as well. So this study is looking at this idea that, body image is more than just weight and shape concerns. It's not just about, disordered weight control behaviors, but it's how you see your whole self, your whole appearance, even your skin tone. And so we looked at the body image influences media, family, and peers, and how that impacts disordered weight control behaviors and the use of skin lightening or tanning products over 3 months. As Malaysian adults and we got YouGov to run the survey for us. So we used their panel and we did quota sampling, and our total sample for Malaysia is 1,200 participants, about 58% women and ages ranging from 18 to 73 years. And they complete an online survey about body image influence, disordered weight control behaviors, and use of skin lightening / tanning products. And I'll show you the questions in a bit. So we actually delivered the survey in Bahasa Malaysia, which is BM, all the local, the national language in Malaysia. About 45% chose to take it in BM, and of which 95% were ethnic Malays. And we compared between those who completed the survey in English and Malay and found no difference in prevalence rates. So we asked the participants, we kind of explained body image is the perception a person has of their physical self, the thoughts and feelings that resulted from that perception. Then who has the biggest influence on your overall body image? And notice that we also gave a fourth option, which we allowed participants to say, no one influences my overall body image. Now, I think Bryn and I have talked about it. Is it like truly no one? Probably not. I mean, we are all influenced by someone, but at least these participants consciously identify that there's no external influence on the way they see themselves. And we also asked, we gave them a list of disordered weight control behaviors as well as skin whitening products. And we asked, in the past 3 months, have you done any of these to control your weight and shape? And for skin products in the past 3 months, have you used any of these skin products to enhance your appearance? Okay, so here are the results. I highlighted in red the ones with the highest prevalence. So it's about 27% of men engage in excessive exercise, and 26% again engage in fasting. Now, the exercising excessively, we really asked them, this is taken actually from the Stanford Washington Eating Disorder Survey. That you push yourself to exercise even when you're tired, in order to prevent weight loss. And the fasting is, we asked them, have you fasted for 24 hours or more to either lose weight or prevent weight gain? And you can see, I highlighted in the box in yellow shows where there's a gender difference, but by and large, the percentages are the same for both genders. The main difference would be the detox cleansing dietary supplements, where we see more women use that. And we see more men using muscle building supplements over 3 months. For skin whitening products, the most frequent one used is cream and lotion. And you would notice there are like 4 different products that we asked for: cream and lotion, injection, pills, and powder and drinks. And I'll briefly show you what that looks like. And for tanning, it's not popular at all. So if we have the thin ideal, I guess, I'm not sure if I can call it, maybe the fair ideal in many Asian societies. And again, we see that for at least 2 of the products, men and women both use it to the same degree, but it looks like more women are using skin lightening or whitening cream and lotion and powdered and drinks. So this is what is most popular in Malaysia. Media images, these are considered fashionistas, highlighting what is considered attractive in Malaysia. You can see that they have really quite fair ladies on of a certain, maybe more slender shape, and that goes for men too. Muscularity is attractive, maybe it's desirable for a certain portion of society, but what we see now is actually I think the less muscle look, but more of, I think, a more slender image, even for men. So again, we see very similar, and sometimes very similar images, more on the slender side, with really fair skin. So here's an example of some skin whitening products. This is a skin whitening drink, and they advertise it really openly. They say this is made with natural ingredients, and it's, if you notice here, I don't know where you can see my mouse, this is MOH approved. And then they post this letter up, but if you read it carefully, I'm guessing that very few of you can read BM. So, but brief translation is actually, it just says that this is not a controlled substance. So because it's all natural, there is no approval or disapproval. But for advertising purposes, this brand has said, this is actually MOH approved. So this is an example of a drink. This is cream, pills that you can take, and injections. And injections not regulated. There has been some stuff about creams. If it contains poisonous, harmful substances, it has been taken off the market, but by and large, readily available in your local pharmacy. So an example of advertising, and then you can, this next one, I'm going to briefly walk you through, did get a lot of negative attention, but the fact that this was actually put out by a fairly popular singer in Malaysia, and even after he took it down, it didn't seem like he really understood why people were upset by what he did. So this is an advertisement for this skin whitening drink. And it starts out, he sings about he has a crush on a girl that is suntanned and of a darker skin tone, and she gets teased, and she gets mean letters by her peers that says in Chinese, "You are so black. Does your mother know?" And so because he has a crush on her, he helpfully gives her skin whitening drinks. And it says on this note in Chinese, when you drink more white soy milk, your skin will become white. And so she does. And she glows after taking the drink. And you can see that everyone surrounds her and really welcomes her. It's a really, I think, it's a terrible message, to say the least, to convey. But this is, I think, even if it's not so explicit, the sentiments are very prevalent in our society. So media is actually was identified to be one of the main influences for women, and family as well. And for men, we see that more men identify themselves as saying, no one influences my body image. But most people, the majority of people, say it's either friends, family, or media. Okay, so, but yeah, 3 in 4 Malaysians. So we want to look at, if you identified family, friends, and media as influencers in body image, does that increase the risk of disordered weight control behaviors and also the use of skin whitening products? So we focus on skin whitening because skin tanning products were not as popular. And this is just a overwhelming table, so you can just focus on the fact that in your purple box, that's the people who say no one influences my body image. Across the board, they are significantly lower percentages of them engaged in disordered weight control behaviors. And again, across the board, significant fewer of them use skin lightening or whitening products compared to those who identify being influenced by friends, family, or media. And so we also ran log regressions to look at calculate risk ratios. We controlled for potential confounders, and a reference group here is the no one group. And it increases, being externally, having an external body image influence increases your risk of engaging in at least one disordered weight control behavior in the past 3 months by about 2 times. And the same for skin whitening products. It increases your risk about 2 to 3 times, and that you're more likely to use at least one skin whitening product in the past 3 months if you identify friends, media, or family as influencing your body image. So, brief summary: it's really high. About 25% of the population at least engage in at least one disordered weight control behavior, and use of skin whitening products. An interesting thing that is we are finding more and more evidence for is that the men and women both are very weight shape conscious, and they show a lot of concern about how they look. The notable gender differences is that women are more likely to use detox cleansing dietary supplements, skin whitening cream, and skin whitening drinks or powder. And men are still more likely to use muscle building or sports performance supplements. So external influence, not great. It increases your risk. I thought it was like, it's really, I would really like to study that group more as maybe as some sort of protective factor. But even among those, the participants who are saying no, there's no external influence, let's remember that at least 10% of them still engage in disordered weight control behaviors and skin lightening cream use. So it's not completely protective. They are still influenced by stuff. So why so high? And I thought this was very, very interesting. I've been quite interested in the work that Diane Newmark-Steiner has put out that talks about that maybe traditional obesity prevention programs could have unintended consequences. They focus a lot on physical activities, diet, and weight control. And by just endorsing these activities, it may actually have increased weight stigma, excessive weight preoccupation, a lot of dieting, and other risk factors for eating disorders. And it says here in this quote that it canceled out the efforts and achievements in the field of prevention of disordered eating and body dissatisfaction. I would say that by and large, we don't have much efforts of prevention of disordered eating and body dissatisfaction. So you can imagine that we've got this force that have unintended consequences, but there's nothing actually to balance it out. And so that may actually be exacerbating the negative consequences. I will use the term, I realize that obesity is, the term obesity is a stigmatizing term, but I'll use it to when I'm quoting some articles that also use it. Yeah, I would just put it out there that it's not a great term to use, but to be accurate to what the source I'm quoting, I'll say that. Malaysia has a really high rate of obesity here. It says it has actually the highest rate of obesity and overweight individuals among Asian countries. And so this is something the government has been really concerned about and devoting a lot of attention to in public health. So since 1995, we see this increase of individuals with a BMI of at least 25 and above. And one of the reasons it's been hypothesized to happen is the rise in GDP. It's a phenomenon called nutritional, oh, good grief, I forgot the word. But anyway, we have more access to high caloric foods, and our jobs don't demand that we move as much. So that's been attributed, a possible reason why we see this increase in higher weight. So since 1996, there's been obesity prevention strategies laid out, but no evaluation of these interventions. And so the behavioral change interventions usually focus on nutritional knowledge, controlling food intake, and increasing exercise. And there are some system level interventions like sugar tax. So what does it look like? This is taken from the Ministry of Health website, and you can see there's an image there of a lady who lost weight, and in Malay, in BM, I translated it into English. It says energy taken. If your energy taken exceeds the energy used, you're going to weight gain. Energy taken is less than energy used, weight loss. So it's very simplistic. And it actually gives out strategies for weight loss of at least 1 kilo a week. Tells you to decrease your food intake by 500 calories, increase moderately intense physical activities by 90 minutes a day. And it'd be really interesting to hear your reactions to what is really common in Malaysia. The information put out there. In the latest strategy, MOH actually talks about creating a calorie conscious society. And so they've been wanting people to count calories and encouraging people to really note everything. And I mentioned that, religion comes into play because there's been some studies that show Ramadan does not increase the risk of disordered eating, but actually in Malaysia, fasting during Ramadan with the purpose of losing weight is explicitly encouraged. It's seen as kill two birds with one stone strategy. Like if you're fasting for religious reasons, why not just add on fasting to lose weight? So it's actually encouraged as well. And we've found some evidence that there is a higher prevalence of fasting among Malays compared to the other ethnic groups. There's also been some, I'll just mention like children, the BMI being reported in report cards. I think that's been done in certain states in the US, and as well as the BMI being used as part of someone's workplace performance. So this is an example of how that looks like. This is actually from a hospital. And you can see the stigmatizing language used. These days, people ignore the content of the food, too lazy to exercise, and we need to eat right and live a healthier lifestyle. The easiest thing we can do is to climb stairs. And so the next thing this hospital did was to help to ensure that hospital staff control their weight and health. They will they'll be rewarded if they're of a certain BMI. In other professions, in the police force, they're actually penalized for being over a certain weight. And as I mentioned, there's no evaluation, but other research from other countries suggests not great strategies. So BMI and report cards for kids is a potential increase in weight stigma and eating-related behaviors. A program in Singapore called the Trim and Fit program that focused it was a school program that identified kids of a certain weight and made them come early to school and do intense exercise or moderately intense exercise before school started and during recess, and also controlled the food they took. And that actually has been shown to been associated with increased weight stigma and increased rates of eating disorders. And the final one of linking it to work performance, and that's I think particularly disadvantageous because that's often used against women in the workplace. So women, this is a recent case that was last year. This flight supervisor was 0.7 kilos heavier than what was allowed based on her height in the company's grooming and uniform guidelines manual. And she brought it to court, and that case was dismissed. And the chairman here quotes that the court is convinced that the company has provided the claimant with ample opportunities and chances to comply with the company's policies, and that despite the many opportunities, however, the claimant has consistently failed to achieve her optimal weight. So there's nothing that this is unfair and unfair policy. In fact, the chairman said, sure, you had many opportunities to lose weight, and now you are justly fired for that. So again, it's not really encouraging any form of health with these sort of policies. So our future directions, and I'll wrap up, and why I really enjoy, I think enjoy is not a good word, why I really admire, I think, the approach that Stripe is taking is because it's taken what has been traditionally seen as a women's issue or only a mental health issue and making it mainstream. And something, by linking it to physical health, I think it's a really good foot in the door approach to bring in, professionals of different areas and help them to attend to this. So, obviously we do need to look at and assess whether these interventions are even working and what the unintended consequences are. We can look also at integrating weight management and eating disorder prevention programs. I'll mention here that actually there are no specialized eating disorder treatment programs in Malaysia. That also needs to happen. If people seek help, where would they go? And as our interests are very diverse at Stripe, we're also looking at skin tone dissatisfaction and addressing a really, I think, interesting project potentially developing is to take material developed at Stripe about colorism and adapt it to the Malaysian context. So more broadly, and there's a power prism taken by Stripe, and go like, where are we going? Honestly, I take it one step at a time because there's so much work to do. And where, decision makers are concerned is decriminalization of suicide. So I'm trying to balance that out by providing them with information and from individuals with lived experiences and empowering those individuals. Where grassroots are at is just focus on mental health awareness, but there's only so much of that we can do. Before I think the public actually gets tired of that constant message. So what I'm trying to do is I'll be a little bit one step ahead and going, what is the next piece of information we need? If people are convinced that mental health matters, what would they need next to inform policy and invest in mental health? So I'm very bad at the other areas. Fundraising, I'm awful at that. So thank God for people like Bryn who's been supportive of our efforts. But yeah, and that's all for me. And so thank you to all my collaborators and thank you to everyone who's been listening in.
Wonderful, fantastic, and so encompassing and comprehensive, this presentation. You really cover a lot of ground from the history all the way through our most recent studies. And kudos to you for what you and your colleagues at Relate have been able to achieve so far, just since 2015. Very impressive. I want to encourage the audience to put your questions in the Q&A, and we'll get to as many as we can. We have about 10 minutes for Q&A, and then we can also follow up. I want to flag for Suk that one of the questions in the Q&A is from a colleague in Pakistan who wants to connect offline to talk about collaborating. So we'll make sure that information gets to you so you can follow up with that audience member. And then actually the first question, Suk, if you can see in the Q&A, is in Baha Malay. And if you can see that, you could.
Yeah, it just says, good evening. What's the link for the presentation?
Great. Okay. So
great.
I let everyone know we're recording this, and within about a week, we will post the recording on the Harvard Chan School website and on the Stripe website. And we'll also send a notice out to everyone who registered that the recording is there. So if you couldn't stay for the whole time or you want to share it with colleagues, you'll be able to do that. Keep an eye out in the next few days or week for that. All right, so I'd love to, we have several questions piling up here. I wanted to ask a first question around gender, Suk, and then we'll pull from more questions coming in. I know you mentioned a few places where there were gender differences in some of the disordered weight control behaviors or the skin lightening behaviors, but for the most part, there weren't gender differences. And I'm wondering if that's probably surprising to many in the audience who may be more familiar with data from Western Europe or North America or Australia. So I'm wondering if you have thoughts on why if in many ways there is not a gender difference in the studies you're doing in Asia.
Yeah, I was actually looking into that yesterday. I was wondering whether there's actually a study done that looked at whether there's the weight bias for men. Is there still a weight bias for management level men? And apparently there is. So I think across the board, being of a certain weight is not viewed positively. Maybe more acceptable, but definitely not viewed positively. These public health campaigns and obviously the media images that you see, both men and women are shown certain images that I think encourage them to to lose weight, to diet. So they don't really differentiate with that. And something that we've talked about too that I'm fascinated by is Korean culture. It's been very influential in Asia, across the board, and the ideal image there is sort of a man with very low body fat, but very slender, very slim, and almost the androgynous look. So I think that's been possibly contributing, but we need more data for that.
Thank you. Thank you. So we have a couple of questions to dive deeper into the findings you presented from our most recent research that's underway. One of them is, have you had a chance to explore how the disorder weight control behavior or those types of symptoms are may be related to skin tone dissatisfaction or skin lightening behavior? Have you seen a relationship, and what does that look like when people may experience both?
Well, our colleague Nadia has done that, and she does show that they're related. So, body weight shape concerns also predict skin tone dissatisfaction and use of skin whitening products. So it suggests to me that people are looking for a certain appearance, and in that appearance is all encompassing, which is a certain shape, a certain weight, but also a certain look and skin tone.
Yeah, thank you for that. And I think it really underscores the need in the research area, a lot of different research areas, but in the eating disorders or disorder weight control behavior area of research, much of the work has focused more narrowly on a conceptualization of body image, really more from a white perspective, where skin tone is ignored in that work. But now your work and Nadia Craddock's work and a number of others is starting to show, wait a minute, we need to step back and have a more encompassing understanding of body image that can take into account the way that colorism and the discrimination that happens around that is part of people's experience that may be interwoven with the experience around pressures to be thin or weight stigma or weight discrimination. We have another question from Nadia Craddock. Wonderful. I'm so glad you could join as a collaborator on this research. A question about whether there's patterns or if you expect to see patterns of difference by urban versus rural areas. I'm not sure if we explored that in our study, but you may have some more insight on that.
Yeah, we haven't. You're right, but some data by Viren Swami in the UK, he looks a lot at Malaysia. The Malaysian population suggests that the ideal image in urban areas, like thin ideal internalization, is higher in urban areas compared to rural areas. So possibly, I'm guessing that following that, we would see higher prevalence in urban areas compared to rural areas.
Great, thank you. And then another question we have from a person asking about the Indonesian context and how that may be related. In the last decades, especially in Indonesia, statistically, there's a trend with mental health awareness increasing in society, especially among youth. So we're seeing differences for millennials and Gen Z, but the awareness hasn't yet translated into changes in access to mental health services. There's some gaps in translating all the way across from awareness that we're seeing in the younger generation to more. Do you have thoughts of how those gaps might be bridged?
Yeah, that's a great question, a very complex one. I think you're right. The thing with public health campaigns is that often they target only one segment of society, right? And what is effective for maybe youth is less effective for people of the older generation. We do see a growing awareness and more readiness to seek help among young people. In terms of reaching the elderly, I think actually that we kind of have a one-size-fit-all intervention approach. So what's more comfortable for them? I've talked to a number of teams about this, and I said, like, if for them, maybe it's not talking to a psychologist. Maybe it's about gathering as a society, as a community, you know, sitting around the table and drinking tea, and something that they can't do right now during COVID-19 times. So for them, that's been something that they've done all their life, and when that's taken away from them, when they're put into home care for the elderly, and if that social interaction is lacking, they may not actually, you know, forcing them to talk to a psychologist and seek mental health care may actually not be helpful for them. So I think it's about working with them to go what's the best fit for them, and giving them the autonomy to participate in their own treatment plan in that sense. Yeah. So I think you can create awareness, but it's going to be different, speaking different languages and different interventions. Yeah.
Thank you. That's so important of thinking about the generational differences and the right messaging and the right kind of services that will work in different age groups. I want to note our colleague Nani Kratik, who also does a lot of work in Indonesia, it resonated your point about Korean popular culture, and she notes that in their work with colleagues in Indonesia, Korean popular culture and Japanese popular culture have been very influential around these kinds of issues.
Right.
We
Absolutely.
probably have time for one more question before we need to wrap up, but I want to let the audience know, if you're interested in getting involved with Striped or getting in touch with Dr. Chua and the research that she's doing with Relate, please just email us. You can striped@hsph.harvard.edu. And you'll also be able to get in touch with us through the email you've gotten about this event today. So you can find Striped and email us. So the last question we have time for is asking about, well, so what strategies can be used to reduce the unintended consequences of the anti-obesity campaigns in Malaysia? What do you think it's going to take to combat that?
I think first we need data. We need to convince people that there are these consequences. I think they are, you know, and being mindful that that this is a public health concern, because we have a large population who are not eating healthily and not exercising, and that leads to a whole other, you know, many other health issues. So it's not so much about saying drop the campaign, but I think it's convincing them that what they're doing is not actually leading to better health. You know, so we have to show that it's, one, not working, and two, it's actually maybe worsening physical and mental health. And with that, then I think creating better strategies to help people live healthily.
Thank you. Thank you. So I'm wondering if you have any last words you want to say about Relate, or how people can get in touch with you at Relate, because I know some of the audience is really interested in talking with you more about what you're doing through that organization. Any last words?
Any help is much welcomed. I'm not a, I feel like I'm a small clinical psychologist with a very big problem. So you can find us at relate.com.my. We also have social media, Relate Malaysia. But yeah, I would just love to hear and learn from your expertise, and be happy to work with anyone. Yeah.
Great, thank you. I mean, it's such a impressive work that you all are doing, and we're so pleased to have you as a virtual visiting scholar this year with Striped. And I encourage the audience, please get in touch with us, get in touch with Dr. Chua at Relate, and we can talk more about ideas you have or collaborations or anything that interests you about this work. So a heartfelt thank you to Dr. Chua for such a fantastic presentation for us today. A reminder to the audience, this is recorded, so we'll post the recording later, and you'll be able to share that with colleagues or go back and review anything that you wanted to see again from her talk. So with that, we will wrap up for the day, and we'll say goodnight to Dr. Chua, who has joined us from Singapore very late in the evening for this presentation. Thank you, everyone, and thank you, Dr. Chua.
Thank you. Thank you for having me.